Good morning to you all. It is my distinct privilege to be initiating the proceedings of this prestigious oration. Now I invite Professor Suri to introduce the oration.
Minor change. Before we start with the proceedings, I request Professor M. Srinivas, the Director of AIIMS, to welcome the orator with a bouquet, please. Now I request Dr. Sashwat to carry forward with the proceedings.
He's been my teacher and my mentor. Yeah, it's an honor and a proud privilege to introduce this oration. So Banerjee's oration, this is the sixth in a row, Professor A.K. Banerjee. This oration was actually started by, we had neurovascular CME and international workshop in 2011. And from the savings of the grant, we gave it to AIIMS. And this is an institutional oration, actually. This is from the institute, from our director and dean. And it was decided that we'll have orations in the name of our emeritus professors. We have two emeritus professors, Professor P.N. Tandon and Professor A.K. Banerjee, who started the department. And every alternate year, this would be an oration, and on the event of the annual microsurgery workshop, which will be there, and to be taken by an eminent scientist and skillful neurosurgeon. Thank you for coming, Yuri. And to introduce Dr. Banerjee is now 92 years old. He's at his home. He doesn't travel too much these days. Born in 1934, he did his schooling in Allahabad, and then he did his MS and his MBBS and MS in KGMC Lucknow. After that, he did his neurosurgical training. That time there was no MCH, it was MS neurosurgery. It was MS neurosurgery in CMC Vellore. So he was appointed as the lecturer of CMC Vellore way back. I don't remember the dates. So after that, he came to AIIMS in 1965 as assistant professor, then associate, then professor. He was then the chief of Neurosciences Center. And then after his retirement, he was working in Apollo Hospital, then Vedanta, initially Vimhans, and then Apollo, and then Vedanta. And he has been a very adventurous neurosurgeon, a very excellent neurosurgeon, par excellent. And he started the Department of Neurosurgery with Dr. P.N. Tandon. P.N. Tandon initiated it, and he started. He was instrumental in developing the Neurosciences Center, the red building which you were operating in yesterday, and the Neurosciences Center, the MRI Center, and our microsurgery lab in which we had the microsurgery practice and workshop day for yesterday. And he started some neurosurgical departments in Libya and in Iraq. And he's taken many presidential orations. I don't have the list, I'm sorry, because the slides are not there. So, and he has a lovely daughter. Madam passed away a few years ago, and people who don't know, she was of a very noble family, and as a hallmark of nobility, she donated her body to our anatomy department at AIIMS for our MBBS teaching. And this is his family, the students that have passed through here. I want to especially show the photograph of one Dr. Tushar Arora. That time he was slim as a resident. So I'm sorry the slides are not there. So we welcome you, Yuri, for your oration. Please, thank you so much.
Thank you so much. It's my distinct privilege to introduce the Dr. A.K. Banerjee orator for 2026, Dr. Yuri Pilipenko. This is Dr. A.K. Banerjee. He was a pioneer microneurosurgeon who started microneurosurgery at AIIMS and was a pioneer vascular surgeon. And nobody is more apt than Dr. Yuri in this august audience, who is perfecting and propagating the art of microneurosurgery as an orator for this year. So Dr. Yuri works at NN Burdenko National Medical Research Center for Neurosurgery in Moscow. He's one of the largest and one of the most prestigious neurosurgical institution in Russia, to put things into perspective, it is actually AIIMS New Delhi of Russia. And this institute began in 1929 and older than AIIMS, which started in 1956 and was later renamed after Dr. Nikolai Burdenko, was the founder of Russian neurosurgery. And it is one of the very innovative department with a lot of clinical innovation and scientific development. The institute has for neurosurgery 20 plus operating rooms, advanced diagnostic imaging, and they operate more than 10,000 cases in a year of neurosurgery, which is again one of the highest volume centers in the world. Dr. Yuri graduated from Vladivostok Medical University in 2005, and his interest in brain date back to 2000 when even his first course he is interested in seeing the brain anatomy. Then came the residency, which and successively perfecting the art of microscopic neurosurgery. And this is in 2009 at Burdenko when the department hosted Dr. Yassergil with his teacher in the art of microneurosurgery, Professor Shalva. He has more than 20 years of experience in vascular neurosurgery and performs more than 250 cerebral vascular surgeries annually. He has expertise in aneurysm, AVM, and complex cerebrovascular condition, as we have seen over the last 2 days. His surgical skills on aneurysm are exemplary. He's also interested in all other things like AVMs as well as cerebral vasospasm in SAH. He has a lot of publications on that. He has authored more than 120 scientific publications. One of the very well cited is publication is this one-line principle in classification of cerebral aneurysm clipping, which is probably he will discuss in this oration as well. Along with that, he has also worked on giant aneurysms, double extra intracranial microvascular anastomosis for giant internal ICMC aneurysm, 3D modeling and augmented reality, and as well as complications of aneurysm surgery. His research interests mainly are on the cerebrovascular pathologies and virtual reality. He is married with 3 children, and his hobby is playing volleyball. So much so that even at AIIMS in the last 2 days, he has not forgot to pursue his hobby. AIIMS budding collaboration is going on for a couple of years. When we have hosted them, their faculty and resident, and reciprocally, they have also hosted us in Russia of late. And like India Russia strategic partnership, we hope that this collaboration be one of the biggest medical neurosurgical institutes go on to higher levels. And we are honored to have Professor Yuri with us today for the AK Banerjee Oration. Please join me in welcoming him. Thank you so much.
Dear colleagues, good morning. Thank you for introduction. For me, it's big pleasure, big honor to be here. Thank you, organization committee, for invitation, and of course, I enjoy this meeting. I'm very impressed that it's possible to join our experience with you to do work with you in your operation, and it is very interesting, of course. And my topic, as was said, about one-line principle in classification of cerebral aneurysm. It's new classification that we developed, and if it this pointer. So, as you know, there are a lot of operation in our institution, and the last years, as you can see here, we have approximately 1,000 operation for aneurysms, for cerebral aneurysm. Traditionally, we have more microsurgical cases for treatment of cerebral aneurysm. And Yes. Our choice, our algorithm based on the classification, based on the publication, where we decided how we treat aneurysm, microvascular or microsurgery or endovascular way, and there is no competition between these methods. And basically, I would like to say that majority of ICA, vertebral aneurysm, and similar operated by endovascular route, and for microsurgery, we choose generally MCR aneurysm, AC aneurysm, and some distal aneurysm too. Sorry. Yes. I see. Okay. And here we are. Because very big image. So this is the result for last 2 years. We had 1,250 patients with 1,050 cerebral aneurysm. This is only for microsurgery. As you can see on this slide, the majority of aneurysm was operated by traditional classic clipping. We also developed bypass surgery, but microsurgery with classic clipping is still alive. We have had very few complications in this surgery, and as you can see here, only one patient died with high-grade subarachnoid hemorrhage, and good complete occlusion was reached in these patients. About classifications, there are a lot of classifications proposed by famous neurosurgeons from all over the world. But the problem is that I didn't find classification covered all types of aneurysm from different locations, and it was the main purpose of our work to develop it. Our work based on the interesting article from Japanese, this Professor Nishikawa and colleagues published the work, the concept of ideal closure line for clipping of middle cerebral artery aneurysm. They describe different types of clipping of MCA cerebral aneurysm, and according to this article, we also understand that aneurysm defect in the vessel wall have whole oval hole, and the maximum axis of this hole is our main purpose for clipping. And when when we perform clipping, clips blades have line, and we name it closure line. And sometimes it may be direct line, like in this slide. We name this clipping continuous line clipping. Another situation is, for example, wide neck aneurysm. The aneurysm spreading on the different surface of artery, and in such situation, we need to perform so-called fragmented clipping, that each part of the aneurysm neck occluded by different clips. There is example. This very simple aneurysm. It has only one line, too necessary for clipping. Another situation, neck aneurysm, is proposed that it's necessary to clip by 2 clips. So there is, as you can see here, two segments, but this is one line, one angulated line, and each part of this line have to be clipped by different clips. There is comparison between continuous line and fragmented clipping. On the left slide, you can see here if we're planning only continuous line clipping. In the right slide, you can see here if we will be planning fragmented clipping. There is a difference. The main purpose of the fragmented clipping is excluding residual part like this. This is a possible option that can be achieved in this situation. The line clipping is here. Our material based on 678 cases. We investigate different variants of clipping, and first of all, the most frequent clipping that, of course, it was single standard clipping with single clips. But sometimes, it's impossible to stop filling the aneurysm dome. That's why we perform additional applying of clipping distal and to initial one. This is just only for reinforcement. The first line, closure line, is achieved by first clips. Another clips is necessary also only for reinforcements. Also, one more options, it's reinforcement with booster clips. There is example, very small aneurysm, AIIMS aneurysm. Such surgery generally very fast, clear, and easy without any problem. Sometimes we may perform surgery with one clips in wide neck aneurysm like this picture. This is the surgery. We applied only one curved clips put on the aneurysm neck, and this good relation between curvature of the clip and the aneurysm neck, and this is the result of clipping. Another situation, at first glance, it looked like a very easy aneurysm, but if we look closely, there is a little reading aneurysm neck and the two surfaces of bifurcation, and you can see this is operation. This is attempt applying one conventional clip, but there is a remnant. There is remnant. That's why we use bayonet shape clips to exclude aneurysm on two surfaces of bifurcation, apical surfaces and lateral surfaces of bifurcation. It's a good decision for this situation, and this is the result: total occlusion without any complications. So there is also small aneurysm, but the main difficult in this situation that walls of aneurysm included atherosclerotic plaques. That's why one clipping applying does not insufficient for total occlusion of aneurysm, and additional clip only for reinforcement, because line of clipping was formed. The first clip and additional clips was applied only for reinforcement. Another options, as I said before, booster clips, very good options for so-called calcified aneurysms. You can see here one conventional standard clips put on the aneurysm neck, and there is residual filling on the angio, ICG angio, and this booster clip put on the first one. Result clipping. You can see here good filling, penetratory, and total occlusion of the aneurysm. And then clipping. Very popular option for aneurysm clipping the last years. There are 4 types of different for clipping with tandem options. Basically, we perform this method in so-called aneurysm with heterogeneous walls, including calcified and atherosclerotic plaques. The first, this is a classic tandem clipping described by Drake. The first straight clip exclusion, one part of aneurysm, and the other residual part exclusion from the second conventional clip that applied adjunct to the first one. This is the result. It's a post-operative CT angio. Of course, like others method, this method can be reinforced with additional clips, like in this wide-necked aneurysm of middle cerebral artery, also clipping with straight fenestrative clips at first on the one part of the aneurysm. Under temporal occlusion parent artery, the walls of aneurysm very soft, but we use method of clipping to divide it neck to several segments. There is a little remnant that also applied additional mini clip, and there is so-called distal reinforcement. There is a result of this is a result of this clipping, total occlusion of aneurysm, and then clipping is also etched with conventional clips like this AIIMS aneurysm. One part on the superior part of AIIMS occluded with one standard clips, and to adjunct the initial one, we put additional conventional clip, and one line is formed from superior to anterior walls of the anterior communicated artery. This is the result. Counter clipping. This is new term that we included in our classification. The main difference that tips of the clips face to each other. In typical variant of this clipping, the spring mechanism in opposite sides. In this, we included only two clips. So in some cases, we perform also reinforcement with distal parallel clipping or central reinforcement with one clip. This is the example. Very useful options for if we need to make some angle between parent artery and like this outgoing artery. If we need to make so angle, we use this method of clipping like this, very helpful us to decide this situation. This is the result. This is a counter clipping with central reinforcement, AIIMS aneurysm. There is a third branch on the posterior part of anterior communicated artery. And it was complex feature. There is third branch on the posterior part, residual filling, and that's why we use additional clips on the central part of this aneurysm. Result of clipping. Another situation, complex aneurysm, middle cerebral artery. We need to make our reconstruction from M1 to M2. Sometimes it's difficult, but and there is also severe adhesion between efferent artery and aneurysm dome. And we form flow through the M1. M1 is here. So the first clip going from the M1, and the second phase to the first from M2. M2 is here. And additional clips only for reinforcements in this situation, and so-called counter clipping with distal reinforcement. This is the result. Very good occlusion, total occlusion. Cross clipping, I think you know this method. This is very useful method when aneurysm spreading to two surfaces of artery. Like, for example, in this situation, middle cerebral artery aneurysm, the first clip, first conventional clip, occlusion one part of aneurysm, and the second clip, occlusion another part, and the first clip including in the open fenestrated part of the first clip. There is result, and look on this aneurysm. If you solve operation yesterday, very similar situation like yesterday, ICA bifurcation aneurysm with calcified walls. We also in this situation use curved clips that put from left to right direction, and after the revision, after the inspection, we saw little remnant. It is very difficult to occlude this remnant with conventional clips. That's why we used straight fenestrated clips to occlude this remnant. And this is the result, total occlusion, postoperative CT angio. Also, interesting options, double cross clipping. We use these options when aneurysm, when the neck aneurysm spreading on the different surfaces of artery, and this situation, posterior medial part. This is the first cross clipping. After the revision, this part we saw that it's efficient closure, and this the second cross clipping in one aneurysm situation. This is the result, total occlusion. Also, tunneling of the artery. There are two variants of such clipping: tunneling of the efferent artery, efferent outgoing artery. Sometimes it's very good options when we have adhesion between artery and neck of the aneurysm. Some types of reinforcement for this clipping. This is the example, AIIMS aneurysm. The first attempt was with conventional clip that we put at the neck aneurysm, but there is a significant remnant. That's why we removed this clip, because there is also remnant. We remove the clip and put the straight fenestrated clips to include this aneurysm, and we achieved good CT angio results and clinical tool. Another situation, clipping with tunneling efferent artery reinforced with others, with additional fenestrated clips, like a fusiform aneurysm, middle cerebral artery with eccentric part, occlusion with one, and after that second fenestrated angular clips in stacked manner. And this is the CT angio, this is the intraoperative angio to control flow, and CT angio result after the clipping. There are 6 types of tunneling of parent arteries. The most popular, this Sugita tandem clipping in such situation. We use this method in situation when we need form blood flow in the vessel facing to the surgeon, and exclusion aneurysm may be on the opposite side. This is the IC giant aneurysm, this trapping, temporal trapping, decompression of the aneurysm, and tandem clipping with tunneling of the parent artery. preserving the vein, good flow after the clipping, and good angio result after the clipping with clinical good result. The similar situation, M1 aneurysm, also clipping with tunneling of the parent artery, temporal occlusion, and after that remodeling aneurysm flow with angled fenestrated clips. Perpendicular clipping, not very frequent options, but sometimes we use it. There are, it is required a lot of clips for this clipping, and when we perform it, sometimes, you know, aneurysm has like this pica aneurysm, distal pica aneurysm, the walls aneurysm had a lot of intramural clots, and that were resected. And after that, we reconstruct flow in the vessel with putting clips at tips of the clips forming the line. Also, they form the line at the parent vessel. But main difference that line forming only tips of the clips, not parallel clipping like other situations that I showed before. This is the result. And other options also pica aneurysm facing to opposite side. It's not comfortable for traditional clipping, and you can see here this is stenosis after the angular clips, and that's why we use straight fenestrated clip to exclude part aneurysm and forming the flow in the parent artery. Good clinical and good angiographic angio result. So combined clipping, what is it? This is the combination from different clipping methods that I described before. In this picture, the most frequent clipping combination, tandem clipping and cross clipping. This is cross, this and this tandem. This is counter clipping combined with tandem clipping. One of the example, aneurysm, arterial communicated artery. The one part with plaques occluded by straight fenestrated clips, another middle part of this aneurysm occluded with conventional clips, the residual part of the anterior surface occluded with fenestrated clips with cross manner. This is the result of this clipping, good occlusion. And the last, this also new term, discrete clipping. What does it mean? Sometimes it's very difficult to achieve one line, very rare, but sometimes, especially in multilateral aneurysm and trifurcation aneurysm and other complex aneurysm, it's difficult to achieve one line. And there is several lines, you know, clipping this parallel line with no intersecting lines, and this is intersecting lines that can be different shapes, X, Y, T shapes. In this situation, example, multilateral aneurysm, first chamber of this aneurysm occluded with one conventional clip, put it on the one part of the aneurysm, and another part occluded with counter method. But between this line and this line, no connection. So there is two lines of clipping. This is the difference between this method and other methods that I described before. This is the result. As you can see here, there are two lines that formed T-shape clipping like this. And this is our final classification from Burdenko Neurosurgical Institute. If it will be interesting for you, you can find in free access in internet, or my friends, I can send it by message if it is interesting. Thank you very much. There is our workshop in Burdenko for clipping. If you, we also welcome you to our institution to join our scientific session. We will be glad to see you. Thank you very much. This is our department, and thank you very much for your attention.
Now I ask Professor Srinivas, our director, to kindly felicitate our orator. And
One more.
so I ask the dignitaries to please assume their seats on the dais. And now I invite Professor Rajiv Sharma to deliver the vote of thanks.
Good morning to all. It's my distinct honor and proud privilege to deliver this vote of thanks for 6th Professor A.K. Banerjee Oration held today as part of 28th annual Neuro-Surgery workshop. It's our proud. I extend our deepest gratitude to our esteemed orator, Professor Yuri Pilipenko, an expert cerebrovascular neurosurgeon from Budenko Institute, Moscow. This institute is a AIIMS equivalent of in Russia. Professor Pilipenko, your oration titled Micro Surgical Techniques of Cerebral Aneurysm Clipping, a classification based on one-line principle. This principle was truly enlightening and inspiring to all of us. The insights you have shared from your vast experience has enlightened all of us present here. Thank you for taking time out of your busy schedule and honoring us with your presence, with your lectures, and with your extremely exemplary demonstrations over the last 2 days. I thank the AIIMS administration led by Professor Srinivas sir and Dr. Girija Prasad sir for dutifully felicitating this oration every year. Thank you, sir. I am thankful to the visiting faculties, especially Professor Sharma sir and other delegates who have come from far off places and making this annual workshop a extreme success. Now I invite all of you for a short tea break. Thank you.